Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, and I am doing a course on Health Humanities. And today I am going to discuss the concept of other in Health Humanities. Let us know the definition of otherism in Health Humanities. So, in Health Humanities, the concept of other is a critical framework used to examine how healthcare systems, societal norms, and biomedical institutions marginalize, dehumanize, or pathologize certain people or experience. So, drawing from philosophy, sociology, and literary studies, this concept explores the power dynamic between those deemed normal, the dominant group, and those cast aside as different, deficient, or foreign, the other. Coming to the core dimension of other, because even the concept of other is very much popular in literary studies, and this is a literary theory as well. But then, how it's been treated in health humanities, that is important to know. So, the ill person as other, this concept in health humanities defines that society often separates the healthy from the sick. When individuals receive a severe or chronic diagnosis, they are abruptly cast into the kingdom of the sick, alienated from their normal social roles, and reduced by clinicians to a set of diagnostic data. Systemic stigmatization is yet another important aspect to define the whole concept of otherism. So, stigmatization. Healthcare systems historically treat specific identities as deviations from a default standard, usually white, male, able bodied, cisgender, and neurotypical. Race, gender, sexuality, age, disability are frequently othered, leading to clinical bias, dismissal of pain, and unequal access. And these are the categories very much prevalent in society. Naming differently, keeping them in the category of other, different than the normal. Now, next important aspect is medical versus experiential authority. So, mainstream biomedicine positions the clinician as the absolute knower and the patient as the passive object of a study. So, health humanities seeks to dismantle this binary, elevating the patient's lived experience to a valid form of expertise. Now, the other reason. What is this other reason? So, this sub concept highlights non biomedical rationalities such as emotional logic, cultural traditions, or spiritual frameworks that patients use to make sense of suffering, which the clinical gaze often rejects as irrational. Now, there are tables that I'm going to show you to highlight the important concepts within health humanities and what are their actions within the field in accordance with their role in listening to patients' stories and their subsequent reaction. So you see this table, the concept are narrative medicine, cultural humility, and structural competency. And what are the action? Under the category of narrative medicine, using patient stories to build deep empathy, allowing clinicians to see the whole person rather than an alien case. So the entire concept of health humanities depends on this. Coming to the category or the concept, cultural humility, and the action is that shifting from clinical arrogance to open learning, respecting diverse, non Western understanding of health. And then the third concept, structural competency, shows the action that training providers to recognize that a patient's vulnerability is caused by societal structures, not inherent flaws. Now, these are the different categories to define other. How to put into different categories. Now, the sick as the other, as we discuss as the part of the other theory. Another important concept concerning the othering of the patient in health humanity is the sick as the other. It focuses specifically on how the onset of illness creates a sharp societal, psychological, and existential divide between the healthy majority and the ailing individual. Now, sociologist Arthur Frank describes this as being exiled from the Republic of the Well to the Empire of the Sick. Now, see the concept Republic of the Well to the Empire of the Sick, where the people are suffering, and the Republic of the Well, where people are healthy. Dimensions of the sick as the other. So, the first dimension is the clinical reduction. The medical institution frequently strips the sick person of their identity. A vibrant individual becomes diabetic in bed 4, or the lung cancer case, or the patient number. Their unique history, fears, and wisdom are minimized, reducing them to mere specimens to be examined. And this is a very disheartening fact of the clinical process. The moral burden, this is about historically and culturally, when illness is often treated as a moral failure or a lack of willpower. The sick are frequently othered through blame, coded as lazy, irresponsible, or spiritually compromised, implying that their poor health is their own fault. Coming to the next dimension, the aesthetic discomfort. Sick bodies often leak, tremble, lose hair, change weight, or require medical machinery. Because society values idealized images of youth, strength, and symmetry, the visible realities of illness are hidden away in hospitals or treated with social aversion and pity. The chronicity divide is yet another important category of this concept of otherism. Society is generally comfortable with acute illness, where the patient gets sick, plays and patient role, and recovers. However, those with chronic or incurable illness are permanently othered. They frustrate the medical system's desire for a cure and serve as a constant uncomfortable reminder of human vulnerability and mortality. Many writers in health humanities have documented what it feels like to be viewed as the sick. Other, some of them are Susan Sontag, Illness as Metaphor, explores how society wraps disease like cancer and HIV. HIV is still a taboo in society. So, cancer and HIV in punitive metaphors, making the sick person feel alien, contaminated, and socially isolated. Audre Lorde, the Cancer Journal, examines the intersection of being a Black lesbian woman facing breast cancer, detailing how the medical establishment others patients who do not fit the passive compliant stereotype. And Thole Broyard, Intoxicated by My Illness, describes the desire for a doctor who treats the patient's soul and imagination, critiquing clinicians who look right through the sick person only to see the disease. Now, to move beyond the other, as you know, the sub part of the theory otherism in health humanities means dismantling the rigid binaries that separate the healthy from the sick and the doctor from the patient. It requires shifting healthcare from a transactional system of fixing objects to a relational practice of engaging with people. Now, achieving this shift relies on specific clinical practices, philosophical framework, and narrative intervention. And the first intervention is practicing narrative humility. Coined by health humanities scholar Sayantani Dasgupta, narrative humility requires clinicians to realize they can never fully master another person's experience. And the shift is providers must listen to a patient's story without immediately trying to fit it into a rigid medical checklist. And the goal that acknowledges that the patient is the ultimate expert on their lived experience, removing the clinical arrogance that creates the other. The next dimension is moving from empathy to solidarity. Traditionally, empathy can sometimes reinforce the binary. A healthy person looks down or across at a suffering other and feels sorry for them. And the shift is that Health Humanities advocates for solidarity, recognizing that health and illness are a fluid continuum, not two separate kingdoms. Means the two mandates. The goal is to understand that we are all universally vulnerable, bound by shared human fragility rather than divided by clinical diagnosis. So, coming to the next aspect, that is the co-constructing care, that is shared expertise, dismantling the power dynamic requires changing how medical decisions are made. The shift is moving away from paternalistic medicine, where the doctor commands, to a collaborative alliance. And the goal is merging the doctor's biomedical expertise with the patient's experiential expertise to create a unified, respectful treatment plan. Next aspect is a structural competency. And moving beyond the other means recognizing that a patient's differences or vulnerabilities are often caused by broken societal structure, not personal flaws. And the shift is that training doctor to see how poverty, systemic racism, and architectural barriers like lack of wheelchair access create the margins. And the goal is shifting the blame away from the marginalized individual and fixing the systemic biases that treat them as abnormal. Moving from empathy to solidarity represents a major paradigm shift in the health humanities. While empathy focuses on individuals' internal emotional capacity to feel for a patient, solidarity transitions that feeling into shared accountability, mutual recognition, and collective socio political action. Health humanities scholars increasingly critique traditional empathy for being passive, transactional, or patronizing, advocating instead for justice oriented, compassionate solidarity. Coming to the limitations of clinical empathy, the first point is maintains the power dynamic. Empathy can inadvertently reinforce a hierarchy. A healthy, able bodied clinician looks across the clinical divide at a suffering other, temporarily imagining their pain before returning to the kingdom of the well. Prone to fatigue and decline is yet another concept. Data shows that medical student empathy significantly decline during clinical rotations due to burnout and systemic stress. Relying solely on an emotional resource makes it vulnerable to system exhaustion. Coming to individualized structural issues, it says that empathy focuses heavily on interpersonal kindness. However, it does not inherently challenge the structural biases, racism, poverty, or institutional failures that caused the patient suffering in the first place. Now, let us see what are the key theoretical tools related to solidarity, because the concept of solidarity is very important in health humanities. Compassionate solidarity. Framework published via PubMed, National Institute of Health highlight how moving past clinical detached concern requires engaging patients at an existential level using arts like poetry to build deep self-awareness and mutual healing. The interpersonal arts approach that is pioneered by contemporary health humanity educators, this methodology shift curriculum away from direct empathy training and towards community engaged, justice oriented collaboration. Again, there is a table which describing the difference between clinical empathy and compassionate solidarity for more comprehensibility. So, see, I have divided the three category features: clinical empathy and compassionate solidarity. So, in feature, it is core question, direction, focus, and end goal. And in clinical empathy is that how does it feel to be in your shoes? That is the core question. Now, in direction, under clinical empathy, one way clinician internalizes patient distress. Then, under feature focus, clinical empathy is emotional connection and individual comforting, while featuring end goal, clinical empathy is patient satisfaction and clinical compliance. Coming to compassionate solidarity, under core question, it is how are our vulnerabilities and destinies linked? Under feature direction, compassionate solidarity says reciprocal cooperation, co-creation of mutual understanding. Then feature focus covers under compassionate solidarity, political awareness and structural advocacy, while the end goal feature covers institutional equity and systemic justice. So, the core dimension of solidarity in health humanities speaks of recognizing independence. Solidarity rejects the illusion of absolute independence. It acknowledges that health and illness are fluid, non binary states. Everyone is universally vulnerable and relies on collective structures of care. Participatory co creation, and this is about moving beyond empathy, means treating patient as active political and creative allies rather than passive objects of care. For example, justice oriented programs use participatory arts such as patients and medical students co writing music or narrative to build equitable shared goals. Now, alliance against systemic harm, solidarity shifts a provider's role from a detached observer to an active ally. It moves a clinician from simply comforting an individual experiencing medical bias to actively working to dismantle the institutional structures driving that bias. Transition from empathy to solidarity in health humanities. The transition from empathy to solidarity in the health humanities relies on a specific structural, ethical, and political framework. Rather than treating solidarity as a vague emotional ideal, scholars and practitioners break down into actionable dimensions that transform the clinical relationship and healthcare delivery. Coming to the four core dimensions of solidarity within the health humanities include epistemic justice and co-creation. Solidarity fundamentally shifts who is seen as a source of legitimate knowledge in healthcare. Second is valuing experiential knowledge. It elevates the patient's lived experience of illness to the exact same level of authority as the clinician's biomedical data. Third is dismantling hierarchies. Practitioners and patients work together as collaborative partners to co create treatment goals, care plans, and health narratives. Fourth is democratic dialogue. It replaces the passive clinical interview with mutual dialogue, ensuring the patient's voice directly shapes institutional care. So, the structural competency and political alliance says that solidarity moves the clinical focus away from individual biology and towards the external forces that create illness. Some of the important aspects of solidarity in terms of structural competency and political alliance include recognizing systemic harm. It demands that health professionals look beyond a patient's immediate symptoms to see how poverty, systemic racism, food insecurity, and poor housing impact health. From witness to ally, a practitioner acting in solidarity does not merely feel sorry for a patient facing systemic barriers. They use their institutional privilege to fight those barriers. Then, advocacy as care. Political and social advocacy are treated as core components of medical practice rather than optional extracurricular activities. Coming to collective care and mutual flourishing, and they highlights that traditional medicine treats illness as an isolated individual misfortune. Solidarity reframes health as a collective public resource. And the first point is community centered healing. It prioritizes the health of communities and marginalized groups over purely individualized, privatized medical solution. Preventing burnout through connection, it recognizes that clinical burnout is often caused by isolation. By building community based networks of solidarity, providers and patients protect each other's mental and emotional well being. Coming to the shared accountability, healthcare systems are designed to be accountable to the public they serve, ensuring sources are distributed equitably based on collective need. So, universal vulnerability and independence, and in the health humanities, universal vulnerability and independence serve as foundational concepts that challenge the traditional biomedical view of the body as a self contained, independent machine. By drawing from continental philosophy, feminist ethics, and disability studies, these twin concepts dismantle the artificial barrier dividing the healthy, independent provider from the sick, dependent patient. Instead, they reframe human existence as inherent, fragile, and fundamentally connected. First, let us explore important aspects about universal vulnerability. And the first point is shared human fragility. Traditional medical culture often treat illness as an exceptional crisis or an individual failure of the body. In contrast, health humanities posits that vulnerability is the baseline condition of human life. Shared human fragility is a foundational concept that shifts the definition of vulnerability from an individual medical defect, universal feature of human existence. This framework rejects the Western ideal of the invulnerable, completely independent bodies. So, the core principles of shared human fragility highlights an ontological reality. Vulnerability is not a temporary crisis, a pathology, or a weakness found only in the sickness. It is an inescapable condition of being alive. Having a physical body means being permanently susceptible to environmental harms, accident, disease, and time. The myth of the normal body says that this concept deconstructs the medical standard of the perfectly functioning able bodied norm. Health Humanities argues that health is a temporary and highly porous state. We do not occupy two separate worlds of the well and the sick. We exist on a single, shared continuum of physical fragility. In the clinical setting, shared fragility levels the hierarchy between the provider and the patient. While the doctor possesses biomedical knowledge, they share the same existential vulnerability as the person on the examination table. Both are subject to the same laws of biology and mortality. A catalyst for ethics is another important aspect of this vulnerability. So, because human fragility is universal, caring for one another is not a matter of charity or pity. It is a fundamental social and ethical obligation. Our shared exposure to suffering forms the basis of human empathy, collective responsibility, and solidarity. So, the inability of the body says that vulnerability is not a pathology or a defect found only in the sick. It is an inescapable ontological reality born from having a physical body that ages, undergoes injury, and will eventually die. Rejecting the illusion of mastery, this concept directly critiques the cultural expectation that humans should maintain absolute control over their health. It reframes dependency not as a personal weakness, but as a predictable phase of the natural human lifestyle. The fluidity of the health emphasizes that the border between being well and being sick is highly porous. Anyone can cross into illness or disability at any moment, meaning everyone belongs to a single continuum of physical vulnerability. Now, let us look at some of the important aspects of the interdependence in terms of disability in health humanities. So, interdependence webs of care over autonomy, and Western bioethics heavily privileges individual autonomy. The idea that patients are isolated, self governing decision makers. Health humanities challenges this by asserting that human beings are thoroughly interdependent. Relational autonomy says that true health and decision making do not happen in a vacuum. A patient's choices are always embedded within and shaped by relationship with family, community network, and institutional system. The illusion of independence says that no individual is entirely self-sufficient. The able-bodied, independent adult relies on hidden infrastructure such as agricultural worker, supply chains, and municipal sanitation to maintain health, making independence as collective illusion. Reciprocal clinical encounters says that interdependence reconfigure the clinical relationship. The provider is not a detached, unaffected technician. Both the patient and the clinician are mutually impacted and transformed by their human interaction. So coming to the key theoretical background about vulnerability and care, Martha Feynman's vulnerability theory, that is very important in this regard. Martha Feynman argues that because the vulnerable subject is universal, institutions, including healthcare system, must be structurally designed to provide continuous resilient asset of care rather than treating care as an emergency intervention. And the ethics of care says that formulated by feminist philosophers like John Toronto and Virginia Held, this framework asserts that caring for dependents is the primary moral obligation of a society, shifting the focus of justice from abstract individual rights to concrete collective caregiving. Coming to the key literary and theoretical voices about vulnerability and care, Judith Butler, Precarious Life, explores how our bodies are inherently vulnerable to other and to environments. Butler argues that recognizing this shared precariousness is the starting point for global ethics and nonviolence. Arthur Frank, the wounded storyteller, describes how illness forces individuals to confront their fragility. Frank asserts that sharing these stories allows the wounded to become guides for others, turning individual suffering into a shared human resources. Now, in this sense, in health humanities, introducing concepts like shared fragility and interdependence radically transforms medical culture by dismantling its historic focus on detached mechanical perfection. It shifts medicine from a culture of crisis management and clinical detachment to one of relational care, structural awareness, and sustainable practice. This cultural transformation redefines clinical education and practice across four major areas. The first is from detached concern to narrative humility. Traditional medical culture trains a student to maintain emotional distance to preserve objectivity. The transformation, Health Humanities replaces this clinical detachment with narrative humility and active presence. The practical impact, clinicians stop treating the patient as a puzzle to solve. Instead, they listen to the patient's story as a complex narrative, acknowledging that the patient holds vital expertise on their own suffering. From the illusion of omnipotence to embracing limits, medical training historically breeds a culture of perfectionism, viewing death or a failure to cure as a personal or scientific defeat. The transformation is that acknowledging universal vulnerability removes unrealistic expectation that medicine can conquer all human decay. And the practical impact is that providers learn to sit with uncertainty and shift their goals seamlessly from curative interventions to high quality palliative and comfort care, reducing unnecessary invasive end of life treatment. Next is from individual burnout to collective resilience. The classic medical hero archetype pressures clinicians to work through exhaustion, leading to systematic burnout and mental health crisis among healthcare staff. And the transformation, recognizing that providers are also embodied, fragile beings, removes the stigma around clinicians' vulnerability. The practical impact is healthcare institutions switch from surface level wellness apps to structural changes such as sustainable shift length, peer support network, and psychological safety in the workplace. Then, from cultural competency to a structural competency, traditional medical culture often treat patient non-compliance or health disparities as individual or cultural flaws. The transformation, the curriculum shift towards structural competency, training providers to see the upstream social forces shaping health. And the practical impact is that doctors act as institutional allies. They look past the biological symptoms to address the legal, financial, and environmental barriers like housing instability or food desert that prevent healing. Coming to the dimension of cultural paradigm shift from pathocentric to cosmocentric, that is, whole person. Traditional medicine operates on a pathocentric model. It focuses entirely on the pathology, isolating the disease as a mechanical malfunction. The health humanities shifts this to a cosmocentric or holistic perspective, viewing the disease as an integral event that impact a person's identity, relationship, community, and existential meaning. From epistemic monopoly to epistemic pluralism, and for over a century, biomedicine held an exclusive monopoly on what counted as legitimate medical knowledge, quantitative data, lab values, and clinical scans. The paradigm shift introduces epistemic pluralism, asserting that qualitative patient stories, cultural traditions, and experiential wisdom are equally valid and rigorous forms of data necessary for healing. From asymmetrical power to democratic alliance, the historic culture of medicine is deeply hierarchical and paternalistic, casting the physician as the active, all knowing savior and the patient as the passive, compliant object. Health Humanities flattens this hierarchy into a collaborative alliance where the co creation of care honors both the clinician's technical expertise and the patient's self knowledge. From a culture of mastery to a culture of accompany, And this says that traditional medical culture treats death, aging, and chronic illness as failure of science or individual willpower. So, the new paradigm shift, the ultimate goal of medicine from the total mastery over nature to the art of accompanying, knowing how to stand alongside a patient in the face of inevitable human limitations, vulnerability, and mortality. The catalyst of the shift, narrative and artistic method. And this shift is not achieved through reading traditional medical textbook, but through active engagement with the arts and humanities. By analyzing literature, writing poetry, studying visual art, and practicing theater, health professionals develop the metacognitive skills needed to step outside of the rigid biomedical mindset and see the clinical encounter through a completely different cultural lens. Universal vulnerability and independence between provider and the patient highlights that looking at how the relationship of universal vulnerability, interdependence, and solidarity rejects the false binary that separates the permanently healthy provider from the broken dependent patient. And we can conclude by revisiting some of the important aspect, that is shared fragility. It operates on the philosophical understanding that illness, aging, disability are universal human experiences that everyone will eventually face. Mutual dependence. It replaces the myth of absolute individual independence with the reality of interdependence, acknowledging that healthy societies rely on collective, interconnected webs of care. And relational ethics, clinical relationships are reframed around mutual human connection, recognizing that both the patients and the provider are impacted by the healing encounter. With this, I wrap up the discussion. Thank you. Let us meet in another lecture with a new topic.